Today, we are going to make ACL tear simple without making it shallow. The ACL is the knee's anti-slide and pivot control ligament. The common trap is this: an ACL tear is not diagnosed by the pop alone. Instability, exam, associated injuries, and goals matter. By the end, a patient should understand what is happening, and a resident should know what decisions matter. Start with the anatomy. For ACL tear, the important structures are ACL, PCL, medial and lateral menisci, collateral ligaments, femoral notch, and tibial footprint. Do not memorize the picture as a list. Ask what each structure is trying to do when the person moves. In real life, the problem sounds like this: a pop, fast swelling, pivoting pain, and the knee giving way when changing direction. That story is the doorway into the diagnosis. It tells us which tissues are likely overloaded, irritated, torn, compressed, or failing to share load. The core mechanism is non-contact pivot shift, valgus load, anterior tibial translation, rotational instability, and associated meniscus injury. This is why two people with similar images can feel very different. Tissue appearance, load, inflammation, nerves, strength, and confidence all interact. For the lay viewer, the question is not, what word is on the scan? The better question is, what system is failing? For the resident, the question is sharper. What is the pain generator, what is the structural risk, and what can safely wait? A practical way to think about almost every orthopedic problem is tissue capacity versus load demand. If the load is temporarily too high, the answer may be calming and rebuilding. If the structure has mechanically failed, the answer may need repair, reconstruction, replacement, or protection. The common symptoms cluster around pop, rapid swelling, giving way, loss of confidence with pivoting. Symptoms matter most when they form a pattern. One symptom by itself can mislead. A cluster is much more useful. Listen for timing, load, swelling, night pain, mechanical symptoms, and whether the person is losing trust in the limb. Also listen for what the problem has taken away: sleep, walking, work, sport, independence, or confidence. The best history is not a questionnaire. It is a map of what loads reproduce the problem, what settles it, and what function is disappearing. The exam should not be random. For this topic, deliberately check Lachman test, pivot shift, effusion, collateral, and meniscus screen. A good exam separates pain from weakness, stiffness from fear, and joint disease from referred pain. For patients, the important idea is that touching one sore spot is not the same as understanding the whole problem. For residents, every test should answer a question that changes management. If a test is painful but does not change your plan, it is theater, not medicine. Good examination is selective and kind. Imaging helps when it is matched to the story. The useful imaging logic here is X-ray for fracture, MRI for ACL fibers, bone bruise pattern, meniscus and cartilage injury. An image is evidence, not a verdict. The same report can mean different things in different people. The skill is to connect the image, the symptoms, the exam, and the person's goals. That is the difference between treating a scan and treating a patient. A useful image question is: did this picture reveal the diagnosis, confirm the severity, exclude danger, or help plan treatment? Treatment is a ladder, not a reflex. For ACL tear, the practical ladder is rehab, brace only for selected low-demand knees, reconstruction for pivoting goals, criteria-based return to sport. The first steps usually try to calm the painful system and rebuild capacity. That means load management, targeted strengthening, mobility when appropriate, and clear expectations. Injections, braces, procedures, and operations are tools. They are powerful when used for the right reason and disappointing when used as shortcuts. The best plan explains not only what to do, but why that step belongs at this moment. A good non-operative plan has a dose, a time frame, and a review point. Without those three, the patient is just being told to wait. Failure of treatment should also be defined honestly. Is pain unchanged, function worse, strength not returning, or the diagnosis probably wrong? Those are different problems. When surgery enters the conversation, the question becomes, is there a structural problem that matches the symptoms and has not responded to sensible care? Surgery should have a job description. Pain relief, stability, decompression, alignment, repair, replacement, or prevention of deterioration are different jobs. The patient should know what surgery is expected to improve, what it cannot promise, and what rehabilitation will demand. The resident should know the anatomy at risk, the failure modes, and the decision points before entering theater. The most mature surgical decision is not simply, can we operate? It is whether this operation solves this person's actual problem at an acceptable cost. Resident-level pearls, acute hemarthrosis differential, Segond fracture clue, graft choices, meniscus preservation, tunnel position, return to sport testing. Always name the differential diagnosis before falling in love with the first diagnosis. Always ask whether the proposed treatment matches the biology, the mechanics, the time course, and the person in front of you. If the story is atypical, slow down. Atypical pain deserves a wider lens. On a ward round or in clinic, present the case as a decision, not a biography. Diagnosis, severity, risk, options, and what you recommend next. The resident who can explain a condition simply without lying about complexity is already practicing at a higher level. Red flags and urgent features include locked knee, multi-ligament injury, vascular concern, common perineal nerve symptoms. Red flags do not mean panic. They mean the pathway changes, earlier assessment, different imaging, or urgent specialist review. For patients, this is the safety net. For residents, this is how you avoid anchoring on a common diagnosis while missing the dangerous one. The take-home model. The ACL is the knee's anti-slide and pivot control ligament. If you remember only one thing, remember this. An ACL tear is not diagnosed by the pop alone. Instability, exam, associated injuries, and goals matter. OrthoVellum is about making orthopedics visual, honest, and useful. Simple enough to understand, detailed enough to respect the medicine.